Thank you for that kind introduction. Dr. Nihal De Silva, Chancellor of IIHS, Dr. Kitsiri Edirisinghe, Chief Executive Officer, IIHS, Vice Chancellor, President of the Scientific Committee, guest speakers, researchers, members of the faculty, dear students. At the outset, let me very sincerely thank Dr. Edirisinghe and the faculty for inviting me as the keynote speaker at the 27th BioInquirer Annual Research Forum on the theme All for Health, Health for All, Collaborative Innovations for Equitable Healthcare. I consider it an honor and a privilege. This topic, All for Health and Health for All, and I have asked, are we ready, is not only close to my heart, but also relate very directly to the work I have been involved in for most part of my career in medicine and public health, and also in community development the last 3 decades. The concept of health for all originated, as you all know, with the WHO, the World Health Organization, in 1977 and was launched as a global goal through the Declaration of Alma-Ata in 1978. The declaration proclaimed primary health care as the key strategy to achieve a level of health that would permit all people to live socially and economically productive lives by the year 2000. The origin of Health for All movement was a response to inadequate and inequitable distribution of health resources globally, particularly in developing countries. The key milestones include the 1974 Lalonde Report of Canada, and this report was amongst the first government documents to propose that health was influenced by more than just medical care, identifying human biology, environment, lifestyle, culture, and healthcare organization as key determinants. Then, of course, the 1977 WHO resolution, the World Health Assembly, the supreme decision-making body of WHO, adopted a resolution in May 1977 declaring that the main social goal of governments should be the attainment of health for all their citizens by the year 2000. Then, of course, the watershed moment was the 1978 Declaration of Alma-Ata. This landmark international conference, co-sponsored by the WHO and UNICEF in Alma-Ata, now called Almaty, Kazakhstan, defined and promoted comprehensive primary health care as the path to achieving health for all goal. Then, of course, 40 years later, the Global Conference on Primary Health Care, Astana, was held. And on a personal note, I have had the singular honor and privilege of contributing to a book chapter, Achieving Health for All, Primary Health Care in Action, published by the Johns Hopkins University, where I studied in 2000 to mark the 40th anniversary. 2020, to mark the 40th anniversary of Alma-Ata Declaration in 2018. Now, when you look at the core philosophy of Alma-Ata, the philosophy emphasized that health is a fundamental human right and a worldwide social goal requiring a multi-sectoral approach that extended beyond medical care to include areas like agriculture, education, housing, and addressing systemic causes of poverty, which we also are struggling even today. Now, what's the relevance today to primary health care, the concept of primary health care? While original target of 2000 was not universally met, the health for all principle remains highly relevant and is a foundational concept in health policy today. Social justice and equity. The core message of Health for All is a call for social justice, emphasizing health equity and the need to target vulnerable populations. Despite progress, inequities, and inequalities in healthcare access persist. This is highlighted in the 2024 Population Reference Bureau report, PRB report, which indicates that about half the world's population lacks access to good primary health care, a gap that could cause an estimated 60 million preventable deaths by 2030. 2030, as we all know, is the end point for the present SDG of SDG goals. The report estimates that scaling up primary health care in low and middle income countries could increase average life expectancy by 3.7 years. 3.7 years. This highlights how a lack of primary care negatively impacts life expectancy globally. Then universal health coverage. The principle heavily influences the achievement of UN Sustainable Goals, particularly, of course, the SDG 3, which commit to achieving universal health coverage and providing access to safe and affordable medicines and vaccines for all by 2030. Then addressing social determinants of health. The holistic view that health is affected by broader social and environmental factors such as poverty, education, climate is widely accepted today. Current health policies and initiatives aim to address these root causes, not just treat diseases. And the global crisis that we are facing today, the COVID-19 pandemic and other ongoing humanitarian and climate crises have underscored the urgent need for robust, resilient health systems and equitable access to health care for everyone, reinforcing the critical importance of health for all vision. This key theme continues to be a rallying cry for public health activists and policymakers alike, advocating for health to be treated as a basic human right rather than a privilege. In 2023, when WHO celebrated its 75th anniversary, the famous slogan, Health for All, was chosen again as the theme for celebrating the World Health Day of 2023. If you look at the global situation, as it was mentioned earlier, the half of the world do not have access to proper health care, and also the expanded definition of that same report says that an approach to health that is integrated, tailored to individuals and families' needs, and delivered as close as possible to people's daily environment. And I'm going to, in a minute, go into what's happening in Sri Lanka in that direction. The definition is expansive compared to the definition of primary health care in 1978, since adequate health service must meet a population's changing needs. The needs that we face today are quite different to the needs or the realities that we faced in 1970s when Alma-Ata Declaration was launched. This includes care at every age, during pregnancy, through childhood and in old age. Our Sri Lanka's population and housing census report was released just 2 weeks ago. We have a high elderly population and a decreasing young population below 15 years, and this is a challenge which requires us to reorient our healthcare and other social care delivery systems. It also includes addressing non-communicable diseases while containing infectious diseases, some of which have been earlier controlled and now again being on the increase. In essence, primary health care helps people to live longer, healthier and also happier lives. So let's move on to the situation in Sri Lanka. Sri Lanka is also no exception to what's happening in the world. Despite having one of the most effective public health care systems in the world, in the developing world, with indicators that are at par with high-income nations, the COVID-19 pandemic and the economic crisis that followed had a devastating impact on the population, mainly the poverty-stricken and marginalized communities. Nutritional indicators worsened to alarming levels, which are yet to return to pre-COVID-19 levels, even though pre-COVID-19 levels of nutrition status amongst children in Sri Lanka was also not very satisfactory. If you look at Sri Lanka's progress as well as challenges, Sri Lanka has historically subscribed to the principle of primary health care and has made significant strides in achieving higher standard of health despite a low per capita investment in health. The famous quote, "Good health at low cost," is attributed to our nation, our country, Sri Lanka. Despite these achievements, however, challenges such as regional disparities in health outcomes, limited healthcare access to certain populations such as the communities in the plantation sector, resource constraints, and growing burden of non-communicable diseases remain. In addition, things like rising out-of-pocket expenditure despite we having a universally free healthcare system is a challenge. Sri Lanka continues to work towards strengthening its primary healthcare system to address these challenges and ensure that all its citizens have access to high-quality healthcare services. In this regard, a novel approach was adopted by the Ministry of Health in 2019, and some of the senior administrators who have been working in the health ministry are here, so they are very familiar with this novel approach and also all the challenges that the administrators faced in trying to change this system. This innovative approach, what is known as the Shared Cluster Model, was introduced as part of a World Bank funded Primary Healthcare Strengthening Project or PSSP. The Shared Cluster Model is designed to enhance the delivery, accessibility and quality of primary healthcare services. This model emphasizes collaboration among various health service providers within a designated geographic area cluster, encouraging resource sharing, coordinated care and community involvement. So the key features of the shared cluster model include decentralization of services, integrated care, shared resources, community engagement, capacity building, and data sharing and monitoring. This your research forum is about evidence-based analysis and also learning. In our country, we have enough and more data. Research findings from what you are going to present today are available, but unfortunately, this data, this evidence is not really translated into policy and also implementation. These key features of the shared care cluster, this model, in summary, aims to improve health outcomes by making primary health care more efficient, patient-centered and responsive to community needs. In Sri Lanka, adapting this approach aligns with ongoing efforts to achieve universal health coverage and strengthen primary health care system. Despite resource constraints and changing disease patterns. A geographically demarcated area for curative care is identified through GIS mapping. Then populations living within that area is empaneled to hospitals. Then population know that the nearest hospital is their hospital, and there is in Sinhala they say Lagama Rohala Mage Rohalai. That was the essence of this model. And continuity of care provides seamless access to curative care. Planned specialist care are also available for the empaneled population. And it also has emergency care for the empaneled population. And empaneled health seekers get priority when they are referred up. Cluster hospital considered as one entity for development, cadre, data, finance, supervision, drug and reagent estimation and distribution. Now, though this is what was proposed and also piloted in a large number of districts, still I don't think this was integrated into the system, because we treated that as a project, and unfortunately it has not really yet to get integrated into the system, and there's a follow-up project hopefully with that. This concept, I'm a firm believer of this, that we need to change, and this is a good way forward. So the success of the shared cluster model, particularly post-implementation of PSSP, I can elaborate on just mention these 4 points. Clustered services led by divisional hospitals and the curative care institutions become the focal point where most of the services can be provided without the patients having to bypass the primary care institutions and ending up in secondary and tertiary care hospitals. Then improved referral systems and continuity of care. We cannot impose referral system on patients. I am also personally against that. It has to be a choice, but we have to somehow convince our population that they should not go to secondary and tertiary care hospitals to get primary care. Then better resource allocation and service integration. We know that there is a lot of wastage in our health system, and having a decentralized, very integrated, high quality model like the shared cluster model can really save resources, particularly at a time when Sri Lanka is still recovering from a terrible economic crisis. Then strengthening preventive and curative linkages. This is also very fundamental to having universal health care. So the future outlook is like this. We need to make primary health care more efficient and patient-centered. Then we have to support universal health coverage, though we are not too bad, but compared to some other Asian nations like Thailand, we are behind in UHC. Then we need to address resource constraints and changing disease patterns as well. And we have to ensure equitable access to all Sri Lankans. Now, again, referring to the census report, we could see very clearly some disparities are also very geographic and across different socio-economic strata. Local innovation and resilience. This seminar is also this forum is also about innovation. I think there are a lot of local innovations happening. They can be social innovations in new models like what I have referred to here, but also technological innovations which are for preventive and curative healthcare as well. Community partnerships. We have seen IIHS going to the community, but can there be more partnerships? We as equal partners rather than they becoming recipients of our services. Then power of local leadership and trust is very important. In the introduction of my bio, it was mentioned that there's a Lancet Commission, and I'm honored to be a part of that commission that is looking at the faith and trust in healthcare. Because COVID-19 and also the economic crisis showed how community-level social protection prevented people from drifting into poverty, ill health. So I think this power of local leadership has to be recognized, and we should have partnerships with communities. That is what one of the principles of community engagement. Now, we need structural and systemic changes. Ladies and gentlemen, addressing present and future public health challenges in Sri Lanka requires us to look beyond traditional healthcare delivery systems. What brought us here will not take us where we need or want to be in the future. Addressing social, economic and political determinants of health is not just a moral imperative, but it's a practical necessity. We know that our health systems are underfunded, there is corruption and wastage and also resource gaps. Health workforce migration and stress is also affecting our health system. Then social determinants such as poverty, education, water and sanitation, etc. are also of paramount importance for us to address. Then we need to remind ourselves of the principles that are also based on the primary healthcare principles in building resilient and equitable health systems. We must recognize that health is shaped not only in hospitals, but in our own homes, schools, workplaces, and policy chambers. By taking a holistic, collaborative approach, we can ensure that every Sri Lankan, regardless of their background, has the opportunity to live a healthy and fulfilling life. Community-centered, equity-driven healthcare is important. We need to recognize that recommitment to primary healthcare and probably the shared cluster model that we have initiated is a viable model. Then also digital transformation for inclusive and equitable healthcare. I think we can really use information communication technology and also digitization in improving our services better and also making the population access services in an equitable manner. Then cross-sectoral collaboration is very important, where we all know now that health services alone cannot improve the well-being of the population, but we need to also work across sectors. Then finally, adaptability and crisis preparedness. For example, the COVID-19 may be the first pandemic that we have faced in our own lives, but it's not going to be the last pandemic. Therefore, how could we prepare health systems and also communities to face future pandemics? I would like to end by drawing your attention to something that we have been working for more than 25 years in Sri Lanka. Though we have a universally free healthcare system in Sri Lanka, our constitution doesn't guarantee right to health. We need to commit ourselves to building a future where health is not just a free service, but a fundamental right to all. We now have a charter for patient safety and well-being, which has been prepared and approved by the Parliamentary Oversight Committee on Health that was during the previous government. I sincerely hope that the present government, as promised in their manifesto, it's very clearly stated that they will bring a charter to safeguard patients' rights. So this charter is in the form of a committee report now, and we hope that this will be adopted. It's very important. Organizations like Sri Lanka Medical Association have been advocating for this for more than 25 years. Adopting a charter for patients' rights, protecting patients' rights, can be the first step towards someday we having health as a fundamental right in our constitution. In conclusion, health for all remains a fundamental guiding principles. I remember very well about 30 years ago when I was still a young public health student. One professor who was working with the founders of the concept of primary health care reminded that health for all should be written as health for all with ALL in capital, not health HEALTH as capital. Whatever the level of healthcare that should be provided should be for all. That is already ingrained in that principle of equity. So here, I think health for all and all for health, even all for health, is all of us for health, and all commit together towards health. So as medical professionals, it's our duty to prioritize well-being and welfare of all Sri Lankans, especially during these difficult and uncertain times. We must take active steps to fulfill this responsibility without delay. This is the true meaning of all for health and health for all. Thank you very much.